Hi everyone, this is again Dr. Pan from Taiwan. My second talk is on painful peripheral nerve entrapments and how to diagnose clinically. I have nothing to disclose either. So again, back to the previous slides showing that there are many pain generators for our pain patients, including degeneration, nerve entrapment, and scarring adhesion. So we have been discussing the nerve entrapment, scarring, adhesion, and degenerate microtear as well. And we use regenerate for degeneration, hydrorelease for nerve entrapment, and adhesiolysis or hydrotenolysis for refractory pain conditions. So now we go to hydrorelease for nerve entrapment. So the nerve entrapment or entrapment neuropathy happens in the peripheral nerves. So this is the gross anatomy or demonstration showing the detailed structure of the peripheral nerve. And the peripheral has its own innervation we call nervi nervorum, and the vascular supply, the vasa nervorum. So when the nerve is strangled or entrapped, we call it entrapment neuropathy, and which can be shown on the proximal swelling or swollen of that nerve. So this can happen by perineural fibrosis, by a ligamentous compression like a suprascapular ligament, or it can be bony structure like uh, sphenoid notch, or it can be compressed by two heads of muscles like peroneal tears, or a fibrous arch like the fibrous arch of flexor digitorum sublimis. They can be also entrapped by vascular structures or in a connected to tunnels like a tarsal tunnel. So when the nerve entrapment or peripheral nerve entrapment be diagnosed, we can do ultrasound-guided nerve hydrodissection or hydrorelease to solve that problem. And traditionally, a clinical diagnosis relies on some symptoms and signs for that nerve entrapment, including muscle weakness, decreased grip strength, clumsiness, muscle wasting, etc. However, most of the time, the patients presented with very nonspecific and not detectable symptoms or signs, which would cause a challenge to clinical pain physicians. And history taking usually reveal nonspecific signs of focal pain. Although ultrasound can show some swelling or increased thickness of the fascicles, like in short axis or in long axis, which will be more elaborated by Dr. Medina, and the MRI as well. However, is there any other way that we can use, especially clinically, to diagnose or to suspect that there is a nerve entrapment, especially by physical examinations? Well, for carpal tunnel syndrome, for example, there are signs to diagnose that, but they are not very good in specificity and sensitivity. And also in cubital tunnel syndrome as well. And in some severe cases, as for suprascapular nerve entrapment, there was a weakness or wasting of that muscle, which can be diagnosed physically. However, the challenging is that most of the patients' complaints are non-specific, and we pain physicians cannot use that severe signs or symptoms to diagnose. Thus, we usually neglect those patients with pain. So sometimes the only way we can find or suspect is local tenderness. However, it can be a myofascial pain rather than a nerve entrapment. So how to differentiate from these? For example, a painful upper back can be trapezius myofascial pain, supraclavicular nerve entrapment, cranial nerve 11 entrapment, and dorsal scapular nerve entrapment. So how could we differentiate them clinically or physically? And we also already discussed this for lateral shoulder pain, that differential diagnosis should be include not only the intramuscular tendon, intramuscular scarring or intrinsic adhesion, but also the suprascapular nerve entrapment. We also demonstrate that there's a physical way to differentiate them from superficial nerve entrapment and intramuscular tendon scarring or internal adhesion. So this is we already discussed. But for this kind of pain, for example, right gluteal pain, we have to differentiate from gluteus medius myofascial pain from the cluneal nerve entrapment. So it is rather difficult to differentiate these two by not using ultrasound or not using other ways. Even the EMG or NCV would be negative for them. So it is very, very difficult. So that's why I'm going to introduce the scratch collapse test for you to have a more tool in your toolbox to do it clinically. And this is by far the most sensitive way to detect, and it is not just subjective, it's very objective to write it, document it in your chart to see that there's a peripheral nerve entrapment or not. So let me introduce it to you. The scratch collapse test is a simple examination test that is similar in sensitivity to other examination tests to diagnose peripheral nerve entrapment, like cubital tunnel syndrome. So the way to do this is number one, we have to do a pre-test on the left side of screen to see the shoulder do external rotation under resistance. So this is a pre-test. Then we scratch the suspected side of medial epicondyle or the innervations skin area of the ulnar nerve. And then we do the same resistance test. So if the patient has a right side uh, cubital tunnel syndrome, there will be a weakness, sudden weakness of the external rotators of that shoulder, which can be demonstrated not just by sitting, but also by standing. So this kind of effect will last for a couple of minutes, and then it vanished again. So it will be washed out. So by this, we can suspect or diagnose clinically by physical examination, showing that this patient may have a cubital tunnel syndrome using the scratch collapse test. So what about other nerve entrapment? We are doing the same thing, just doing the shoulder resisted external rotation. So the first is also the pretest, doing the resisted shoulder external rotation. And then we stretch the innervation area of the radial tunnel or radial nerve. Then we do the collapse test to see whether this will be weak or not. And for the lateral epicondylopathy or lateral elbow pain syndrome, one of the differential diagnoses is the entrapment neuropathy of posterior antebrachial cutaneous nerve. So how could we detect that? By not by using the ultrasound, we can use the scratch test to do a pre-test. Then we scratch the area of lateral epicondyle. Then we do the collapse test to see whether this is purely mechanical, purely tendon problem, or there might be a nerve component of this lateral elbow pain. Now, maybe you will ask me why should you do this or not doing other ways? The answer is I don't know. The only papers describing scratch collapse tests are maybe 40 to 50. If you check the PubMed, no one discussing about the real underlying mechanism of why this test is so sensitive for these kind of peripheral nerve entrapment. So sorry for this. So back to the exam, we can now using scratch collapse test to differentiate whether an anterior thigh pain is caused by purely rectus femoris muscle myofascial pain, or there might be a underlying anterior femoral cutaneous nerve entrapment. So what can we do this? Now you know how to do this. We do the pretest first, right? Then we do the scratch on the anterior skin area, which the anterior femoral cutaneous nerve is innervated. Then we do the collapse test. So if the patient shows on the hand, not the leg, if that shows the weakness, sudden weakness upon our resistance test, then we can diagnose peripheral nerve entrapment over the right side anterior femoral cutaneous nerve. So here we'll be showing a case with a video case showing that the scratch collapse test in a patient diagnosed with anterior cutaneous nerve entrapment syndrome on the belly. So the anterior cutaneous nerve entrapment syndrome happens with a clinical presentation of anterior abdominal wall pain. And this is caused by a piercing nerve to the skin of the intercostal nerve to the anterior abdomen, and which can be entrapped on the muscular side of the innervated area. So this is how we do it: scratch and then collapse. Okay. Okay, and let me do that again. So we do the pretest and then scratch and collapse. So we can diagnose the anterior cutaneous nerve entrapment over her right side belly. So it can be shown also by standing posture. Oh, collapse, right? So it can be shown either by sitting or standing posture. So the scratch collapse test can be used not only for clinical diagnosis, it can be very useful for confirming what you intervene for these kind of entrapment after your treatment as well. So this is another example showing that the lady has the left side anterior cutaneous nerve entrapment. So before the injection, so you could scratch both sides. The only left side was collapsed. It's so weird, right? Yes, it's so weird. So after ultrasound-guided hydro-release or hydrodissection for this anterior cutaneous nerve entrapment, we do the scratch test again. So see the bandage? Okay, pretest. Then wash out. And then scratch. And then, wow, it became powerful. Okay, so not only for diagnosis, but also can confirm your treatment, right? So let me give you another example. Patient with plantar heel pain, usually we saw that with a plantar fasciitis, but we'd have to do a differential diagnosis to exclude what kind of nerve entrapment? Yes, the Baxter nerve, the first branch of the lateral plantar nerve. So how do we differentiate them? By scratch collapse test, right? So first we do the pretest with hands, then we scratch the innervated skin area of the lateral plantar nerve, then we do the test. So if the patient has real collapse, then we'll do the ultrasound-guided Baxter nerve hydro release, either on position 1 or position 2. And then we do the scratch and collapse test to see if the muscle power goes back. So this is very useful, right? But there are still challenges for this kind of test. For example, the most common entrapment neuropathy of the body is the carpal tunnel syndrome. But the study shows that the scratch collapse test, the author advised against scratch collapse test for carpal tunnel syndrome. Why? We don't know. However, for cubital tunnel syndrome, the scratch collapse test is effective and sensitive. So there's controversial views for these kind of two tests for different nerve entrapment. However, for both entrapment neuropathy, the specificity of scratch collapse was relatively high. So let me conclude our talk. So for peripheral nerve entrapment, we can use many ways to diagnose. And The physical way to diagnose a peripheral nerve entrapment, the most sensitive one, is not the way we think before by using muscle weakness, grip strength, or clumsiness. It's a scratch collapse test. So I welcome you, everybody, to test and to search for internet how to apply these kind of tests for your painful patients. And thank you very much.